Real warm welcome to all of you this evening's program. Many of you whom I've already, at least some of you who I've already met and talked to before. Before we start the program, may I request you all to stand up for a minute's silence to our great ex-president, Dr. APJ Abdul Kalam, in his memory, who was known for his At the outset, I would like to thank you all for taking time out from your busy schedule and coming here. And I'm sure many of you are from outside Bangalore too, and you have already at least had a glimpse of our traffic and what we go through on a daily basis. My sincere thanks to Mr. Sandesh, our Cadabam, and the entire management of Cadabams for all the efforts they have put in to have this program. Thanks are also due to Mr. Rangaswamy and J&J for the help. Personally, I express my gratitude to Dr. Sunil, Pavan, who's here, Koshala, as well as Jose, for all the slides they have prepared. Now, you know whom to blame if there are any mistakes in the slides. It seems quite a long time ago. It was in 1990, when I started my career in psychiatry. That was in Christian Medical College, Vellore. Now that was the first time I started seeing how families were involved in the care of psychiatric patients. That actually I could see firsthand when I worked closely with them, their dedication, their care, love, and involvement, and how it had an impact on the outcome of the illness. Certainly that was an eye-opener. And also there are many studies which have shown that the prognosis or the outcome what we talk in several illnesses, including schizophrenia, is better in developing countries, say India, and one of the main reasons they give is about the involvement of the families. So I dedicate this talk to all the families here and the many countless families who have really taught me and guided me, been my teachers, given me hope, confidence, strength, and been my inspiration and motivation all these years. A warm round of applause to you all actually. So this talk is dedicated to you. I'll try my best to keep it simple. Dr. Sunil, where is he? Right. Please pardon me if I do go away from the slides, whatever you have it, and I certainly promise within the limited time I'll complete it. Okay, thank you. First slide, please. Okay, when we talk about schizophrenia, I'm sure many of you would have either come across in the literature or in movies schizophrenia as in split personality. Now that was the understanding perhaps in the 70s, 80s, even before that. Now psychiatry has come a long way even from the time I started, and certainly that makes me really look old. Perhaps Sandesh was just about a year or two at that time in 1990. But now schizophrenia, we don't see it as something as restricted to personality. However, we see it as a disorder. Now here is a slide nicely prepared. So we have a state as in a psychotic illness, and you can see that the personality is not mentioned at all. However, what you have is a fundamental disturbance in thinking. Now, before we get into the schizophrenia, the details itself, I would like to probably spend a little time on this, the second one, as a psychosis. Now, schizophrenia comes under the broad category as a psychotic illness. And what we understand by psychotic illness, a person not in touch with reality. In simple terms, because I believe understanding anything can be reduced to simple terms. If a person has a dream, whether he is being followed by somebody or which becomes more like a nightmare, anything for that matter, pleasant or unpleasant, when he wakes up in the morning, he knows what's the difference, that it's a dream and that he knows what the reality is. But in a person who is going through or has had a psychotic illness or a breakdown, that distinction is lost. So he is unable to say what is that fantasy, real, or that imaginary world, and what is real. So that boundaries become blurred, and the person starts believing whatever he sees, whatever he hears, anything with reference to him, he starts seeing it as something which is happening. That to the close family members and the relatives, which actually finds it very disturbing, very difficult to understand, but this is something happening to the individual. So however much they try to convince at that stage, no, this is not happening, but the person will insist that this is happening, because for them it's actually happening. So really nothing much, makes, you don't really make much of a headway when you start arguing with them. So schizophrenia is one of the psychotic illnesses, perhaps the more common psychotic illness. There are other illnesses too. Right, next slide please. Now, to make a diagnosis of schizophrenia, we have to, perhaps in any psychiatric illness, we have to rely on the information provided by the family and what we are able to get from the individual. Although science has developed, including psychiatry, however, we have not reached a stage where an MRI scan or a lab test, something which would help definitively to make a diagnosis. So we are still literally groping in the dark where and how. We have to intently listen to what the individual is saying, what the family have observed. So many a times, when a person has had a scan or so, and the brain structure comes back as normal, but here we have the individual going through a lot of problems. Maybe we can take it up during the discussion, but we are fighting with a lot of things what the individual is going through and how to convince him that he or she has a problem. This is just about a word or two about the duration too. If a person goes through any abnormal state, it's not just one day or 1 week. We usually have to wait, get a proper idea how long the individual has been suffering. Now, there you go, continence itself, there is a big difference. If an individual is having any of these probably for say 2 months or 3 months, he's not going to be diagnosed schizophrenia if he were to be in the US. But the same individual, if he is in India or UK, would think about this diagnosis. Now, I'm just trying to highlight that the differences within the medical profession and also the understanding how it changes from one country to the other. So starting with the Audible Thoughts, I'll try and keep it simple, try and make it as much as I can understand, and hopefully I'll be able to communicate that. Now, what we are thinking is only you as an individual would know. Unless you talk about it, then the other person sitting next to you or opposite you, then only they will come to know. However, in a diseased state of mind, what happens is the person thinks and he actually starts hearing his own thoughts. Now, that is what we refer to as Audible Thoughts. So the person thinks, oh, I can think of, I want to have coffee, but I can also hear the same thought coming from outside too. So that actually causes a lot of anxiety. Voices arguing or commenting. Now we all know about, in the olden days, we had this radios, the commentary, cricket commentary, which those days when the television was not so popular, we all had to hear to the cricket commentary on the radio. Now there you have, literally like a commentary, what the person is, he is a right arm bowler, he is coming here and he is bowled and the ball, likewise. So exactly the same way the individual starts hearing also, that there are voices, maybe 2 or 3 or many, who are actually talking about him, commenting on his actions. Maybe the way I am holding the hand, he has raised his hand, he is looking at me. So actually like a commentary which is going on, and that actually again is quite a disturbing thing without having any reasons why this is happening. Just going on the thought withdrawal, insertion in broadcasting in one sentence, we are all in control of our thoughts. However, yes, sometimes our religious heads and spiritual heads perhaps do have a influence on us, the way we talk, think, maybe some people do believe. But in general, we are very much in control of ourselves, the way we think, the way we act, and the way we behave. However, when a person goes through this state, they start thinking from the outside, maybe a source. Commonly we hear some satellite somewhere there which is taking away my thoughts, and I am unable to complete. In the conversation, suddenly they go blank. When we ask, oh, my thoughts have been removed by somebody. Not happening once or twice, maybe several times it's happening. Likewise, with respect to insertion, a person is so confident or so clear to say this is not my thought, but maybe my uncle, my sister-in-law or somebody, or in some cases even mother-in-law blaming, she is putting thoughts in my mind. Okay, so that again the individual is very much convinced. Likewise, the rest of it also, it's just to highlight the individual is going through an abnormal experience for which he clearly feels he is not in control of it, and he is very much in distress, but is unable to believe that this is a state of mind. Next slide, please. Now, how common is this illness? It's just a slide to say that this can occur anywhere in the world, and none of us have any immunity towards this illness. Whether it is a doctor, scientist, politician, you name it, any profession or anybody can get it. Likewise, the age also. Earlier we used to think age group of what we have here, 18 to 25 or 15 to 24, 25, but it can occur as young as 12 years, 13 years, or as old as even 90 years, 95 for the first time. But these are the common ages where it can occur, and maybe we can think about it also, because that is the age where a lot of us are exposed to several stressors. Change of school, maybe going into a new place, having to meet other people. Also the changes, the hormonal changes, it could be some degree of temptation towards drugs, anything which can perhaps trigger this at that. And also these days we all know how difficult it is to get into any kind of college or course what you want, and parents, students, everybody, it is a stressful time, including teachers too. So anybody can get that illness around that age group. Next slide, please. This is just to highlight, we have it here in blue, which is not so visible, but it's to show that how the illness has had an impact. And we, along with HIV, AIDS, road traffics and all that, this carries a significant percentage adding to the mortality, which means death happening earlier than what you would have expected. So an illness state like schizophrenia, which because of various reasons, maybe neglect of physical health, perhaps the other things again which we will come back later, because of say obesity, poor physical health, hypertension, diabetes, and so on and so forth, which will actually, they cut short the life in people with schizophrenia. Next slide, please. We had the first, I think, 1 or 2 slides talking about positive symptoms and maybe negative symptoms. One of the, again, a very interesting thing, when we see, say, 10 people in a hospital or a clinic, not all of them do present with the same kind of features. So that makes it, we have to see the individual, we have to get the information, what is perhaps affected this individual. So we have to take a detailed history. Now, when we refer to positive symptoms, perhaps that is the one which is maybe picked up more, probably earlier than the other things. A person who becomes extremely suspicious, complains of either believing that he or she is being followed, there are some aliens who are out there on the streets wanting to kill, to that extent, including closing the doors, maybe having some special security, that what we refer to as positive symptoms, including hallucinations. We talked about a little about the hallucinations earlier. Now that majority of the people, when they do have that presentation, actually it is for the family also, it is relatively easier to pick up, but because of the abnormal nature in the behavior. Many a times it's the other extreme, the left extreme or to right extreme to you all, is the negative symptoms. In fact, many of them, when they start with the illness, they also to some extent have that also. We all know when they are somebody who's been very active, playing cricket or watching TV, reading newspaper, suddenly when he has had a psychiatric illness, that interest goes down. Something which they are so passionate about, either listening to music, what they have done on a daily basis, you need to start pushing them. Otherwise, they won't even move from the chair. To that extent, one can lose their motivation, their emotional expression. We hear from a lot of families, he was so happy and cheerful before this happened. Now, even to get them to smile, it's so hard. Even a comedy show on a TV doesn't make them. So they are literally, their emotional responses are what we refer to as blunt. Likewise, being withdrawn, not attending functions, not taking part in any social gatherings or festivals, all that gradually being withdrawn, which shows. Some of them who are very good in writing, maybe they're perhaps writing stories or articles. When they write, normally when they write, it makes a lot of sense. However, when they go through illness, maybe they'll write, but what they are communicating, even if it is a page like this or even an A4, which can all probably be condensed to 1 or 2 lines. So what we refer to as poverty of content of talk, that poverty of thinking, that is very much evident. Likewise, we all know that for us to remember something, we have to concentrate. Driving, it's another skill. A lot of people find it very, very hard after having had a breakdown to be able to concentrate, be able to register, change the gears, change, stop. And the memory part of it also, a lot of things what we have mentioned here, the cognition is about thinking. So thinking is slowed down. You ask a question, maybe there is a long pause before the individual's response. So that is something which is a part of the illness. In at least maybe about 10 to 20% of them do present with disorganization. Their behavior becomes very bizarre. Their speech also, I don't know whether my speech right now is disorganized, whether I'm making any sense or not, but it can be. If there is, please let me know. But the speech itself, when it becomes very rambled, and a person, even the close relatives find it very abnormal, they're not able to, that usual logic and rational thinking is lost, but they talk a lot, maybe it becomes incomprehensible. Likewise, some of the mood symptoms, now they are again very, very common. Anxiety, depression is so common. Going through a major illness like schizophrenia, you can expect them to, because it would have had some effect on the last one, the functional impairment, what one is good at doing, whether attending the college, going to work, or being productive. If it gets affected, when they are unable to fulfill their own commitments, they start feeling anxious, they start feeling depressed, and particularly losing job, or if they are not able to return to work, you can expect a lot of changes in their mood. Likewise, self-care. Maybe again during the discussion we will talk, there are number of people when they go through negative symptoms, getting them to brush their teeth, change their dress. We have had innumerable cases wherein we even having a shower, changing their dress, they wouldn't have done for months together. Okay, months together, which is really sad, but that is the effect or the consequence of the illness. Next slide, please. So, when we have an individual with a diagnosis, what are we looking at? To start with, we need to look at control of their symptoms, because that is what one has approached the psychiatrist or the mental health professional. So you need to look at how best to handle that. Yes, we have ways of use of medication, which my colleague Dr. Dhananjay is going to talk about it later. And also change of environment. Many a times being in their own house where they may feel very threatened, probably a short stay in the hospital, short stay in any place, even a change of place, perhaps to a relative's house, would bring down the distress because of the symptoms. Now, had the other housing, income, work, maybe an Indian family, perhaps that would not be a priority, because we expect our families to look after us. And however, in the Western countries where age of 16 and 17 they have to take care of themselves, it becomes the state's responsibility to find an adequate housing to take care of them. But yes, as they get better, you have to think about it. Where would they stay and how would they come for follow-up? All that becomes important. Income. Now we all know that the rates of medicines are going up every day. It's no more that affordable, cheap, and all that we can't associate with particularly psychiatric medicines. But any amount, if they are able to work, it will give them satisfaction. To some extent, it will also take care towards meeting the medical expenses. Now, in fact, social skills, from our point of view, it becomes very, very important. What we all take it for granted when we see each other, maybe smile, maybe shake hands and greet each other, all that we take it for granted and we really don't. But in a person who has had an illness, what we refer to as chronic illnesses, that is one thing, the social skills are very much affected. So that becomes one of the chief objectives in any rehabilitation, which again I think my colleague Dr. Sridevi is going to address later. The last one is about the comorbid, which means along with a psychiatric illness, you have a medical illness, or if it is a gynecological or anything which drug use, substance use, or taking other medication, which could be contributing, which we have to take care also. Next slide, please. Yeah, next slide. I think we can go on with that. Yeah, we have more or less touched on this bit about the perception and the hallucinations. Maybe we can take it up during the question time. Next, please. Yeah, thanks. I want to say that it's not as if all of them who do have this illness are going to present with all the features. Need not be, actually. Some of them could well be only personal hygiene. Some of them it's only about the thinking which is disturbed. And many times we may have to really search for a proper symptom. So yes, disorganized thinking, because of, we all have more or less like our information, what we get it from the outside world. We are able to we are able to selectively take it and we are able to synthesize and keep it. It's like this, you are looking at me now, but at the same time, all the others are also visible to you, including the screen, everything. So, but you know where to pay the attention and how to discard or disregard the other information. However, this amount of the censoring or the able to screen that information is lost. So everything becomes important. So when it does, the individual is going to get really, really disturbed. Next slide, please. This is a nice way of showing how the person, when persecution, as in a person being followed or come off, is it? Sorry about it. Again, being followed by a policeman or somebody which makes the individual extremely scared. Next slide, please. Grandiosity, as in a person believes that he is special, there are many instances where we've had that they believe they are reincarnation of God, or they themselves have the ability to change the world, having all the special powers. So that's also could well be a part of this illness. Next slide, please. Right, okay. Now, we mentioned about hallucinations. It need not always be hearing voices. It could be seeing more like shadows or ghosts, which the other family members may not be able to see. It could well be disturbance in the smell, taste, whether in terms of strong odors. Usually they talk about some poisonous gases which they are able to smell. That could well be something which is a warning sign that maybe the illness has come. And also taste and touch also, if there is a difference where the individual or the family knows that nothing like that is happening, but he is experiencing it. Next slide, please. Now this we have seen. Now it may be inappropriate to us. That is the way we look at it. The person is talking, laughing to himself, but he may have a reason for it, but he may not like to share with us. So he may be having his own inner experiences. It could well be a commentary hallucination, somebody cracking a joke, and he is responding to that. But in an audience like here, suddenly if somebody starts laughing or smiling, laughing or talking, then it could well be seen as inappropriate. We've talked about the negative symptoms, and much of it, the flat effect, is covered under that. Now the last one is these days, in the last 20-25 years, maybe that has not many are seen now. When we refer to this particular word catatonia, where in fact I am reminded of the time in CMC Vellore, where a young boy about 17 years was just standing on one leg, with hand raised, and was stood there for probably about 8 hours, 10 hours doing nothing. So wherein the movement, as in movement is affected, he may become mute, not open their mouth, say any word, not take any fluids, refusing and actively just refusing everything, and also being motionless. Now that is the kind of state which actually is less and less seen, maybe because families are taking them to the doctors early, perhaps medicines are given early so that they are not allowed to go to that stage. Next slide, please. We have covered this a bit about the positive symptoms and negative symptoms. In effect, when we talk about positive, it is about the delusions, what we talked, or the hallucinations. And the negative symptoms, next slide please. Negative symptoms are the absence of the functioning, whether in terms of thinking, emotions. Next slide. Yeah, there you go, the negative symptoms. Thinking, emotions, as well as actions, or the interest and all that which we have talked about it. Now whenever we make a diagnosis, some of them at least would like to look and find out what type of schizophrenia it is. From the psychiatric point of view, this will help making or having different categories just to say how well they would respond. Nothing more than that, because all of them do need treatment. So perhaps the first two respond much better, wherein we talked about suspicion, active hallucinations and all that, or the catatonic one, which is now rare. The rest of them maybe are left with some kind of deficits where they may not completely get better, but are left with a long-term work. Next slide, please. Now that brings us to the course of the illness. A frequently or commonly asked question to all of us is, how long should one take medicines? Okay. Again, in the talk on the pharmacology, he's going to address that. But it's again very difficult for us to put in as to course of the illness, how an individual is going to behave. However, studies from across the world talks about it, where this one, the last one, is probably about 15%, 10 to 15%. So if you look at the figures, about out of 100, maybe just about 15 people have just one episode and they are well, they don't need any treatment. But the rest of them, about 80 or 85%, will fall into the other two categories. The more common ones, continuous or the recurring episodes. Now, next slide, please. That actually makes it, one, clear that there is a huge responsibility on the families, rather than seeing it as just 1 month, 2 months or 3 months treatment and stopping it. You never know, one, when the individual is going to have a relapse, two, with respect to the improvement itself, whether the course is going to be continuous and he needs treatment. So when we have had a diagnosis and the treatment is all started, we have to set our goals too. Number of it which is already there. I think the most important, perhaps to most people here and the patients who take it, is about side effects again. Whether it's about the weight gain, sedation and all the rest of it, which probably is the biggest barrier for them to take the medicines. Unfortunately, all English medicines do have side effects. Let's accept it. However, what suits the individual and how best to balance with the improvement one has made, and maybe we have to somewhere compromise on it and use it. But there are no easy answers for that. It is quite a challenging one. Convincing somebody to take something which does cause side effects is, you can imagine the amount of hard work it involves. These days we talk more about the recovery process, wherein a person may be left with some symptoms, however he is able to function well. We have people who are school teachers who are able to return to school, able to teach, then come back for follow-up or treatment. Maybe they still have here and there some degree of disturbance, hearing voice from a distance, but that doesn't prevent them from functioning what they are good at. Regarding the treatment pharmacotherapy, it's easier actually for me. One will be by Dr. Dhananjay, the other one is going to be addressed by Dr. Sridevi, right? Next slide, please. However, there are quite a few challenges. The biggest, and I think not much has changed from the time I have started psychiatry, is about stigma. I don't know the stigma. It's not about stigma in the lay people or the non-medical professionals. The biggest for me is stigma within the medical professionals. There are a number of doctors, when they have their own relatives, when they have illness, they delay to bring them to the doctors to see the psychiatrist. And many of them who don't want to be seen that they are giving medicines. So the stigma is very much there, and it is going to be there perhaps in the next 50 or 100 years too, because we find it very, very hard to accept it. But it's a challenge. We have to work with the individual families and people. Insight, I don't think we need to say much, wherein there is a big disagreement between the family, psychiatrist and the individual who has to be treated. He or she really believing that there is no problem at all. Third one, as in compliance. Worldwide, it's known that probably about 70 or 80% of them have repeated the illness coming back because they end up stopping the treatment. They take their decisions because of side effects or reasons, whatever known to them, but which is unfortunate, they end up having the relapse because they're not taking the treatment properly. Substance abuse I've already covered. The risk of violence and suicide maybe more in the acute stages, maybe when the illness has started, when they are scared, they don't know how to express, how to explain what is going on. But it is something which we all have to bear in mind. We have to look out for any signs, and we always advise the family to look for too. Medical problems, whether it is about the medicines or, India, we all know, perhaps is the diabetic capital of the world. So along with diabetes, you have hypertension and all the other things also which adds on. So we need to continuously monitor. We need to get the treatment as and when appropriate. Next slide, please. So I hope that I've given a very brief overview on what the illness is, because I believe that when we have the question and answer session, or when we have questions from you, that will perhaps give us an opportunity to understand better. Thank you very much.